See, what happens in asthma is, in very long-term asthmatics, there is a remodeling in the airways. And a disease which is usually reversible in terms of airflow obstruction to start with becomes progressively irreversible as the airway remodeling gets worse and worse. So you have a group of patients who after many years essentially behave like COPD patients. That is one. Secondly, you have somebody who has asthma and who has smoked also. So in these group of patients, you can have predominantly COPD more than asthma. So there is a group of patients who basically behave like COPD. They don't have very dramatic response to treatment as most asthmatics would have.
There is no COPD free cigarette?
No. See, all smokers do not get COPD. You know, it's a so-called susceptible smoker. Unfortunately, we don't know what those susceptible features are in terms of the genetics, in terms of particular HLA classes. There is no scientific evidence. So I think till that day comes, you know, then we may be able to phenotype and genotype and tell these patients you can smoke and you can't smoke. You know, you have risk of COPD.
Particularly those COPD patients, long term, used to do most of the COPD patients echocardiography, and they see that even RVS is not present, but the PAP, pulmonary artery pressure, is above 35, 45, sometimes 55. Those subset of group, whether we are getting more PAP, particularly more than 55, their mortality and the prognosis definitely.
This is a very, very interesting and a very, very topical question you have raised. And actually one of my areas of interest is pulmonary hypertension. Now, this is a very, very sort of exciting area because as you know in the last 5-7 years, therapies are beginning to emerge for pulmonary arterial hypertension. And in fact, I have to give a talk in Ahmedabad next month on hypoxemic lung disease and pulmonary hypertension. Now, there are a few issues here. One is the echo is unfortunately not the best way of diagnosing pulmonary hypertension. And in the West, it is mandatory to do a right heart catheter if you're going to put somebody on treatment. Number two, because the echo may show you, if you look at the correlation coefficient in terms of echo and right heart catheterization correlation to pulmonary artery pressure, there is a lot of scatter. So you have a lot of under and over diagnosis with the echo. Two, it depends on the expertise of the echocardiographer. So you should not look only at the pressure. You have to look at other features. You have to look at the right ventricle. You have to look at the interventricular septum. You have to look at the so-called TAPS, the tricuspid, annular systolic vein excursion, how much that is. And then come to an impression whether it is pulmonary hypertension. Now, unfortunately, even if the patient has pulmonary hypertension, what do you do in these patients? So you can have a situation where a COPD patient has chronic hypoxia. So these patients will have pulmonary hypertension and the treatment is long-term oxygen therapy, as I told you earlier, more than 15 hours a day. So a large group of COPD patients with pulmonary hypertension will need long-term oxygen therapy. Now there is also a group of COPD patients like you said who do not have pulmonary hypertension, who don't have hypoxemia and yet have pulmonary hypertension. Now what do you do with these patients? Because there is no evidence so far that sildenafil, bosentan, ambrisentan does anything very much to these patients. These drugs are very good for what we call class 1 pulmonary hypertension, which is idiopathic pulmonary hypertension, which was in the past called primary pulmonary hypertension, or pulmonary hypertension secondary to connective tissue disease, scleroderma and things like that. And sometimes you do right to left shunts. But so far there have been no good trials which have shown the benefit of pulmonary hypertension therapy in these patients. There is one entity called disproportionate pulmonary hypertension and hypoxemia in COPD patients. So you have COPD which is not too bad. The FEV1 is 60-65% of predicted, but they have pulmonary hypertension. Now some of these patients may actually be having idiopathic pulmonary arterial hypertension. So maybe it is worthwhile to give pulmonary hypertension therapy in these group of patients because they may not be they may be having so-called primary pulmonary hypertension and might benefit. Because one of the problems of giving pulmonary hypertension therapy in COPD or any other lung disease is you can sometimes worsen the ventilation perfusion mismatch. What happens in COPD is a lot of lungs which is not perfused, not ventilated, is not perfused. And suddenly you open up these by giving pulmonary vasodilators. So you can send perfusion to non-ventilated areas and sometimes worsen hypoxia. So even if you decide to treat these patients, you must keep them under fairly close observation in terms of maybe checking their saturations, how they are. And if you find they are benefiting from, say, for example, sildenafil, it's worthwhile to continue. But if not, stop it. So I think you have to be more aware of all these issues when you treat these patients. But this is coming up very, very frequently. And what you get at echo is actually a systolic pressure rather than the mean pressure.
Yeah. And one regarding your personal experience for the type 2 failure.